So, hyponatremia differential diagnosis. This is a very, very high yield topic for clinicals, but less high yield for step one. But I'm going to get into it. So, hyponatremia, when you see a patient like that, the way we divide it first is we look at serum osmolarity. So, you can either be have low serum osmolarity, normal serum osmolarity, or high serum osmolarity. So, if you have hyponatremia and you have high serum osmolarity, then the reason why is it would be due to hyperglycemia. I want to explain that. So this is our blood vessel, their blood, and let's say you have hyperglycemia, you have way too much glucose. So this glucose is dissolved in the blood. So because you have extra stuff dissolved in the blood, the osmolarity goes up. So now you have hypertonic hyponatremia. And the reason why you get hyponatremia is all this glucose, we just said, it increases the serum osmolarity. What's going to happen to the water shifts? Remember, water goes from low to high. So water will shift into the vessels to try to normalize that serum osmolarity. So you're going to get a lot more water in there. But what's going to happen to your sodium? Let's call this our sodium. Well, our sodium levels in the serum is not going to change, but we just add a lot more water. So the concentration of sodium is going to decrease. Okay, concentration of sodium decrease because we get all this water that's coming in due to that increased osmolarity due to hyperglycemia. So that's hypertonic hyponatremia. What happens? What's the isotonic hyponatremia? That's normal osmolarity but low sodium. This one is due to too much protein or too much lipid, and this one's actually a pseudo hyponatremia, and I want to explain that. So pseudo hyponatremia due to too much protein or too much lipid. I'm going to draw actually a beaker here to explain this. So this is our serum. But if we have too much lipid or too much protein, what's going to happen is our volume is going to increase. And the difference here is these guys don't dissolve in the serum, and if they don't dissolve in the serum osmolarity doesn't change. But they're just so big and fat, and they have so much of it that it just their mass increases the total volume. It's like dropping rocks in a cup of water. So you drop a bunch of rocks in a cup of water, you have more perceived volume. So when you measure it, you're gonna think that you have hyponatremia because your machine's gonna see this increased volume. It's gonna see the same number of sodium molecules, so it's gonna think that there's hyponatremia. But in reality, if you actually sample out this fluid, there's just this pure fluid without the proteins or the lipids. The sodium concentration is actually normal. So your body's not gonna have problems because the actual serum, without all that extra stuff, without all the proteins and the lipids, the serum with the stuff dissolved in it has normal sodium concentration. So that's isotonic hyponatremia, aka pseudo hyponatremia. Finally, we have hypotonic hyponatremia, and that's because that's low serum osmolarity, and the low serum osmolarity is because we have low sodium. Because remember, serum osmolarity is made up of many things, and one of it is the sodium. So sodium makes up serum osmolarity. With low sodium, you get low serum osmolarity as well. And this is the most high yield part of hyponatremia. And the way we look at this one, hypotonic hyponatremia, is the most common one, is you look at volume status. So these patients can be dehydrated, they can be normal volume, they can have too much, they can be fluid overloaded, they can be edematous. So let's look at the hypovolemic patients first. So these guys are the dehydrated guys, and they're hypovolemic because they lose sodium. They lose sodium and the water follows. So remember, the sodium is what's going to determine volume status. So sodium determines volume status. If you lose sodium, you lose volume. You have low volume. If your sodium stays the same, you're euvolemic. That means your volume status is the same. If you're retaining sodium, then you become hypervolemic. So we're talking about hypovolemic hyponatremia, where you're losing sodium and water follows. So you can lose the sodium and the water through the kidney. So that's either due to diuretics, where we're trying to make them lose sodium and water, or mineralocorticoid deficiency. Remember, that's where it acts on the collecting ducts for sodium reabsorption. If you're deficient in that, you don't get reabsorption of sodium, you're losing it. And then finally, salt wasting syndromes. So that's the renal losses. You can also lose sodium and water extra-renally. So for example, vomiting and diarrhea, those are both rich in sodium and water. So you're just vomiting it out or diarrheaing it all out, and that's how you get hypovolemic hyponatremia, extra renal losses and renal losses. Next, we're going to look at the euvolemic hyponatremia. That's where their volume status is normal, and this is because they get the hyponatremia from excessive water retention or too much water intake. Their sodium doesn't change, that's why they're euvolemic, but they have all this extra fluid that's going to cause dilution of the sodium, so they get hyponatremia, euvolemic hyponatremia. And I use this mnemonic to remember PATS. So psychiatric problems like polygenic polydipsia and hypovolemia, those cause just too much intake of fluid. You dilute all the sodium out. And the hypovolemia, you're just not eating enough, so you're not getting enough solids, not getting enough sodium. So adrenal insufficiency, this one's a little tricky. Adrenal insufficiency and SIADH go kind of similarly, because adrenal insufficiency causes problems because you have low cortisol. And low cortisol, we don't know why, but it increases ADH. So both of these have too much ADH. What happens when you have too much ADH? This one is SIADH. SIADH was syndrome of inappropriate ADH activity. So too much ADH, remember, in the collecting ducts, you get too much water reabsorption. Too much water reabsorption, dilution. Okay, and hypothyroidism, we don't know why, but it just leads to euvolemic hyponatremia. So that's PAT, psychiatric problems, adrenal insufficiency, hypothyroidism, SIADH. Finally, when we have too much volume, we're volume overloaded, hypervolemic hyponatremia. That's because you're retaining both sodium and retaining water. So you can have this retention either from failure of filtration. So the heart and the kidneys, the heart, for example, you're not pumping out blood, so that stuff's not getting to the kidney, it's not getting excreted. Same thing for kidney injury, the kidney's not able to excrete water and sodium, it's not able to get rid of it, so it just stays in the body. You're going to retain too much sodium, to retain too much water. The other things is edema from decreased oncotic pressure. So what's going to happen is you get decreased oncotic pressure from liver disease, nephrotic syndrome. Or liver disease, you're not making proteins, so you have low proteins, aka low oncotic pressure in the vessels. Nephrotic syndrome, you're just peeing out all the proteins, so you have low oncotic pressure in the vessels, so you have decreased oncotic pressure. And then remember that when you go from low osmolarity to low oncotic pressure out to higher oncotic pressure, so all that fluid goes out of the vessels. So you're going to have less fluid in your vessels, but you're going to have a lot of fluid in the rest of the body. And the kidneys are going to sense that low fluid in the vessels. They're going to increase ADH, and so you're going to retain too much fluid, and then you're just retaining sodium as well. So you get this hypervolemic hyponatremia, and this kind of increased ADH from the low fluid in the vessels is also seen in heart failure as well. Remember, your heart's not pumping blood out that well, so blood's not going to the renal vessels, so you get increased ADH. So that's it for the hyponatremia. Just want to recap. So look at serum osmolarity. Hypertonic is hyperglycemia. Isotonic is the pseudo hyponatremia. Hypotonic is the big one, as you can see. Now you want to look at volume status. You want to see if they're volume down, euvolemic or hypervolemic. And just for clinical knowledge, you look at these volume status through a lot of the overall clinical picture. You look at the history, see if they're vomiting a lot, if they're peeing too much. You look at the physical exam. You look at first of all, their vitals, if their blood pressure is low, if they're tachycardic. That means their heart's beating too fast. If they're you can look at the physical exam findings can tell you if they're hypervolemic, JVD. You can look at a lot of other things. You can look at pitting edema, blah, 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 etc. So if you have hypovolemia, it's either due to you're losing sodium and losing water. You can lose it either through the kidney or through extra renally. Euvolemic, you're just too much water retention, or you're taking in too much water and just dilutes everything. And then the SIADH plays a big role in this too. So just remember the mnemonic PATS. Hypervolemic hyponatremia. I mean, this is the same stuff you always see with the edema. You see heart failure, same stuff: heart failure, liver failure, kidney failure, and then so you get just edema. There's less fluid in the vessels. You get increased ADH, but you're not secreting the sodium, so you get hypervolemic hyponatremia. So that's it for our review of hyponatremia.